Good morning. Yes. So I'm Caitlin Costello from Child Psychiatry, and today we are pleased to welcome Dr. Rhea Boyd and Alex Briscoe. Dr. Boyd is a UCSF-trained pediatrician and child and community health advocate who works at the Palo Alto Medical Foundation and serves as the Chief Medical Officer of San Diego 211 and the Director of Strategy, Equity, and Justice for the Children's Trust, a campaign to expand access to social, emotional, and developmental supports to every child in California. She travels frequently to teach students and trainees about the relationship between structural racism, inequity, and health, and is extensively involved in community-based advocacy. Alex Briscoe is the principal of the California Children's Trust and the former director of the Alameda County Healthcare Services Agency, where he led one of the state's largest public health systems. He has designed and administered a number of mental and physical health programs and services and specializes in Medicaid policy and administration, emergency medical services, youth voice and crisis counseling, and safety net design and administration. Please join me in welcoming Dr. Rhea Boyd and Alex Briscoe.
Thank you. Hey, y'all. So I'm a pediatrician. I did my residency right here at UCSF, so it was easier for me to find this room than Alex today. It's cool to be back. I think this might be a bit of a different grand rounds than you're used to. So the Children's Trust is an initiative that's trying to expand how Medicaid pays for children's behavioral health services throughout the state. So we're going to talk about kind of a policy angle that we're taking to a structural problem in the children's mental health system. So I'm going to kind of tee that up by talking about how we've been framing our approach to those structural problems, and then Alex is going to jump into our policy agenda. So this is kind of how we frame the pieces of our work, which is an evolution in how we've talked about it. Basically, the core of what used to be our work was rethinking about the public financing for children's mental health. But as you can see, that now is on the outside of the triangle, and we've moved equity and justice into the center. Because one of the problems we have in California is that we have a deeply inequitable children's mental health system, whether you measure that by a child's racial or ethnic population, or the county they live in across the state, or the child serving system where they seek their services. Different kids are getting different things, and they're not getting what they need. And we used to think that you could change that by just changing the financing, but we know that's not true. So at the center, we're like, whatever we do has to reshift power in this system in a certain way, and one of those ways is to open up more money. And so Alex is going to talk a bunch about that. We also wanted to reframe how we think about healthy development and center it around relationship building in children's lives and in the systems that they live within. And then we wanted to talk about what does it mean to restructure and restructure and kind of redefine how we administer children's behavioral health services. We used to talk about that as like inviting everyone to the table and everything had equal parts, but now we really know that it won't work unless we put equity and justice at the center, and that's really the conversation that we've been trying to advance. So overall, you guys are aware of this, children's behavioral health is like this umbrella term, right? It's trying to hold a bunch of things. It's holding children's educational achievement, it's holding their social and emotional well-being, their mental health, their adaptive, maladaptive coping behaviors, and any substance use or abuse behaviors they may have. But then we stood back and we talked to a lot of community partners who said to us, like, it's not kids' behavior that's the problem, but when we call it behavioral health and we label their behavior as a problem, then we build systems that try to control those behaviors, which is what we have now, which is the root of some of the inequities in our existing system. When we focus then solely on those behaviors or symptoms, then it misses naming the real root of some of the problems. And most importantly, it misses how the child serving systems we have now, although I'm sure they're well-intentioned, and I as a pediatrician am a part of them, they perpetuate in some ways these same root causes. And so we just wanted to step back a second and talk about what some of those root causes are and potentially ways that we can use Medicaid to maybe address them. So one is family history, that obviously there are inherited and environmental reasons why families will suffer from various mental health conditions. There's emerging research around adversity and around poverty and violence and separation of children from their primary caregiver that results in a number of mental health and physical health conditions as well. And then I use this chart because it also shows that all of those things that we name as ACEs, everyone's familiar with the ACEs literature, right? Okay, amazing. All those things that we name as ACEs, right, also have root causes under the surface and other structural inequities, discrimination, poverty, racism, right, in the community. And so those can happen at an individual level, but also at a systemic level. And then there's this overplay between families who are disproportionately exposed to some of the structural root causes, where then that becomes passed down time and again in your family, not because it's genetic, but because it's environmental sources of racism. When we look across the state, we know that practically every child in California has had at least one adverse childhood experience over their life, and there are areas in the state where kids have had above 70. Those are the 4 red areas, which on this map it's hard to see, but it's at the top: Mendocino, Butte County, for example. And we know, like I said, that ACEs drive behavioral health outcomes. This is just looking at your increased risk for depression or substance abuse if you've had at least one ACE. We also have partners like the Young Women's Freedom Center, which is a community-based organization based here in San Francisco for girls, women, transgender, and gender nonconforming youth, who did a study to look at what are the behavioral health needs of their populations that touch child-serving systems. And what they found, which is a little bit unique from some of the more broader population-level ACEs data in the state, is that obviously, right, there are kids who have an enormous amount of ACEs. Usually you say, your risk increases if you have 1 ACE or 2, and then it stops at 4 or more. But we know there are populations, and the Young Women's Freedom Center serves one of those populations, where the average client has more than 7 ACEs. California has a real problem with poverty. 2 in 10 of our adults live in poverty, nearly 50% of our kids. We now have the highest poverty rate in the country using the supplemental poverty measure, which is different than the federal poverty line because it takes into account the cost of living here in California. There is growing inequality in California, which here in San Francisco we know very well. We lead the nation in that gap. This again is data from the Young Women Freedom Center that looked at, in terms of inequality, like how many times would one of their clients have to move over their lifetime, and where would those moves be in their age range. And what they found is that for kids and youth 13 to 17 and 18 to 21, some of them are moving 15 to 20 times, sometimes because they were being incarcerated, sometimes because they were changing foster care homes, sometimes because of housing instability with their own family. And nationwide, we know that disadvantage overall is growing because of these causes. So now we are one of the first generations where, when you used to say you want your kids to do better, that half of all kids will not out-earn their parents. And we know that racism is a huge cause of that. This is data from Raj Chetty. He used to be at Stanford, but now he's at Harvard, that looks at economic mobility by race and gender in the United States. Here, California is not an outlier. We, like most of the United States, are a place where it kind of pays to be a white boy who grows up to be a white man, because no matter where he lives in our state or across the United States, he's going to earn more in adulthood than he does in childhood. Conversely, if you look at the red and yellow map, there's really nowhere where it's safe to be a black boy who grows up to be a black man, because nearly everywhere he lives, he'll earn less than adulthood than his parents did when he was a child. What the researchers found is that in 99% of neighborhoods across the U.S., including our progressive state of California, black boys are going to earn less in adulthood than white boys. And most notably are the things that he controlled for. So this is even if you grew up in a household where you had 2 parents, right? We used to say, oh, it's single parents in black households. It's not that. It's even if your families had comparable incomes. It's even if you had comparable wealth, right? It's even if you controlled for the wealth gap. It's even if you controlled for the education gap. And it's even if you live on the same city block and go to the exact same school, which might control for things like segregation. What they found was that the mobility gap between black boys and white boys is the lowest where you have areas where there's white people who are less racist, frankly, and more black men in the neighborhood. Now, this isn't black men in your own home. This is black men in your neighborhood, right? So then we have to think about, well, what are the things that are extracting adult black men from communities where kids will grow up and just not see any? So then we have to think about mass incarceration and its effect on the economic mobility of kids and how that affects their behavior when they show up at places like school, for example. This is data from our regional centers. So when we think about how racism impacts kids and their behavioral health outcomes, we also have to think about how structural racism lives within our child serving systems. I think this is an apt example from this year. So what it shows is that where the blue line increases up to the left are areas, so at the bottom are all the 13 regional centers, and as the blue line increases, it's areas where the population that regional center serves is increasingly black or Hispanic. And to the right is the money. And what they find is that there is an inverse relationship between how much money a regional center spends and how many black and Hispanic kids you serve. And so what they found overall is that regional centers authorize lower amounts of money for areas that serve more black and Hispanic youth. We also have been toying with this idea of isolation because across our state, California is mostly a rural state actually by land mass. And so when we think of inequities, we also have to think of areas where there just aren't many services available. There aren't many service providers. The population is very small. We have to think about social isolation within areas that are more populated. And we've been calling it cultural isolation, but what we're really referring there to is white supremacy and the way that it affects people's sense of cohesion and wanting to contribute to government supports for, their neighbors. So here's the state by land mass. And then what that chart shows is kind of how people vote. So we are mostly a rural state, but the population predominantly lives in these blue areas, which is why California is a blue state. So on the right, it shows kind of where the gaps are in our workforce shortages across the state, and it lines up really well with those tiny areas in red. So there are areas where people need a lot more. They don't actually vote for more. They tend to vote red or more conservative and for less governmental supports. And areas where we have a large part of our population, like here in the Bay Area or in the South around LA, where there are relatively more supports. This is similarly looking at adults and kids across the state with just the percentages. So what we did was we said, okay, if we had to name the root of the problem in our children's behavioral health system, what would we say? And we tried to really back up and be as broad as we could about where that problem starts to get as close to the root as we could. And we talked with a number of community-based organizations, and this is what we landed with. That here in California, our kids live within systems and structures and cultural norms that break down human relationships, essentially, that separate families and communities, and that when you separate those human connections, that's what threatens kids. And so it's this isolation of kids outside these family units and relationships that they need to survive and thrive on that really contributes to their behavioral health needs. And so when we said this, we were like, we want to be a relationship-centered project. We want Medicaid to pay for kids to grow up in strong relationships with their core family and at their neighborhood level because of that data we were talking about from Chetty. Just thinking about how our system right now separates families, this is from the Young Women's Freedom Center, who noted that 71% of their clients, when CPS was called, were separated from their family because of that call. The other thing that separates families is, as we were discussing, mass incarceration. Their population was disproportionately affected by having a family member who had been incarcerated, whether a parent or a sibling. And then we know overall, nationwide, that mental illness begins in childhood. It begins when kids would cross through a child-serving system. But typically people don't get care until they go into adult systems where you all care for them. California, for our youth, we're not doing great in terms of recognizing or treating kids' depression when they're teenagers. And we know when we don't do that, it increases kids' likelihood of dropping out of school. We know what happens when kids drop out of school is, especially if you're a black boy, that increases your risk of being incarcerated over your lifetime enormously. This is just looking at some of the recidivism rates. So once you get incarcerated once, your risk of being reincarcerated, or at least rearrested over your lifetime, increases enormously. And so we've been referring to that as the deficit cycle. So if we in our child serving systems right now aren't well serving our kids' quote-unquote behavioral health needs, we know that contributes to their school failure. We know kids drop out of school when we don't do a good job with that. We also know that kids who drop out of school are likely to enter into the criminal justice system, either as juveniles or as adults. And then everyone who enters that criminal justice system, right, extracts that person that people need in their neighborhood, extracts somebody that you need in your family, that core relationship that you need so that you can develop and have healthy relationships. And so the challenge we're facing is really across all of the child serving systems, which is why, as Alex will demonstrate, we're really thinking about how Medicaid intersects with each of those systems and can be used to support relationships and children's social and emotional development. So that's the school to prison pipeline, but we obviously have a healthcare to prison pipeline as well. So in the face of these root causes, our system kind of is managing these symptoms, and right now we feel like we have a choice. One of our close partners, Tia Martinez, said to us, you know, we could make a technical solution. We could say we're going to bring in a lot more money for Medicaid, and Alex is going to tell you how we can do that. And it seems like it's already happening. We'll talk about some policy shifts that literally just came out a week ago from the state. But this solution that we're looking for isn't really a technical one. But if we bring a lot more money, people will say that's a really great job. And so what we really want to think about is what is our responsibility to address these root causes and really shift power in our systems? And how can we hold ourselves accountable to doing that so that we don't perpetuate these same cycles that we know families are caught in? So we made a very clear definition of how we address equity and justice, and I have been the person who's led that effort for us. And so we said, we used a general definition of equity, which says health is equitable, when every child has a fair and intergenerational opportunity to attain their full health and developmental potential, free of any discrimination. But then we said, equity really isn't enough at this point. If we look back at the data and all of the ways in which systems have cumulatively taken or extracted from certain families and communities, we can't now say we're just going to give it out according to need and that that's a fair response. Like, we need a just response, one that says we also acknowledge that certain communities have suffered disproportionately, and those communities we have to address disproportionately. And so for us, that means we have to also have these conversations about power and specifically about racism, which is kind of where we are now. So we're trying to place equity and justice at the center of our work, and we're very open to talking about ways that you guys think about doing that. And now Alex is going to talk more about our policy angle, and then hopefully we'll have time for some open discussion.
Hello, can you hear me? Great. So if I spontaneously combust and you take away nothing else from this presentation, that behavioral health is not just a response to pathology, it's a tool for healthy development and health equity. In fact, I'm going to start with the origins of Medicaid in 1965. So those of you who are geeks may know that Medicaid and Medicare was created in Title 19 in 1965. But what most people don't know is that 2 years later, in the middle of the Vietnam War draft, we pulled 400,000 mostly low-income young men into the draft and rejected over half of them. And in 1967, the military sponsored an amendment to the Social Security Act, which you know very well. It's called Early Periodic Screening and Diagnostic Treatment, EPSDT, the unique federal entitlement that low-income children enjoy under Medicaid that distinguishes them from the adult population. And that amendment to the Social Security Act named 7 benefits. The first, perhaps the most successful public health experiment in the history of our nation, immunizations. 85%. of low-income children get immunizations on time. And do you have to have measles to get an MMR shot? No. We've made a decision as a culture, a social contract, that this is a worthwhile preventative activity. The seventh benefit named in that Social Security Act amendment was mental health. As I'll show you in a second, less than 5% of children in the state are getting anything at all, and a lot of what they're getting is too late and the wrong kind. And some really striking data that I'll take you through that's meant to make you uncomfortable is that you don't have to be a parent of a teenager, something is popping with kids. Extraordinary data that I'm about to show you. It tells you that something has happened in the most prosperous nation in the world. It's like a dark fantasy novel. Twice as many of our children are trying to kill themselves in a 10-year period. It's a really extraordinary thing. What we know in children in California is that now 6 out of 10 are covered by this benefit. This is also something very poorly understood because it's new. In the last 5 years alone, there's been a 35% increase in children in Medicaid. Almost 6 in 10. And you may ask, how do we get there? Well, we rolled in healthy families, S-CHIP. We rolled them in. So Medicaid now covers 0 to 250% of federal poverty. We did this extraordinary act of social justice that no one talks about, which is we put the undocked kids in, SB 75. They are now full-scope Medi-Cal. And then under the Affordable Care Act, we did a really good job of finding mamas with babies who are eligible but not enrolled. So those three things drove enrollment in Medicaid almost to 6 million kids, a 33% increase over 5 years. Now, for the first time in our state's history, 96% of kids have coverage. I have literally spent 20 years working on kids' coverage initiatives, and we can finally put that shit aside and be like, look, it doesn't matter whether you got coverage, it matters what happens to you. This is the data I pointed out between 2006 and 2011, and actually we've done this now data to 2016. There's been a 104% increase in children going to the emergency department for a suicide attempt. So twice as many kids are trying to kill themselves. So that's not about more therapists, that's not about less stigma. That's about kids going to the ED. Emergency department visits for impulse control, which is a weird, funky diagnostic category. It basically means mom and daddy can't handle you and are scared, have increased by 71%. We're spending over $11 billion nationally, and this is the point that I would raise to all of you health system folks, because we all work in an industry, I use that term. While length of stay, butts in beds, has decreased across every disease burden by 30% in the healthcare system, as we went to bundled payment, as we did DRG, right? Good thing. Pediatric mental health is up 50%. And in the last decade, suicide leapfrogged cancer and car wrecks as a cause of death. Extraordinary, right? And I know I don't need to tell folks in this room who are dealing with it every day, but these numbers are, if in any other disease burden, there was a doubling of ED utilization in a decade, we'd have FEMA flying in helicopters on every quarter. But because these are poor, largely black and brown kids, for some reason it doesn't matter. We can't summon the public will to respond. It's shameful. And schools are ground zero for this crisis. And for many years now in Alameda County, I worked in FQHCs for children's hospitals, starting clinics in schools. They make great sense. They work really well. And San Francisco's also done the San Francisco Wellness Centers. And despite these nationally recognized initiatives, we have failed to respond. While more children are eligible for services, fewer are getting care. Since 2011, when the state block granted mental health services to counties, did anybody know that that happened? Okay. This is good for healthcare folks to know. Reagan called it devolution. Brown called it realignment. Same thing. When one level of government gets freaked out about its budget exposure, it bundles stuff together, sends it down to the next level, and caps its responsibility and says, now it's your problem. That's what happened in California in 2011. Children's mental health was realigned, devolved, block granted to counties. And what always happens in block grants? Administrative needs are met, poor people get less. Every single time it's happened in the history of our nation. So since 2011 realignment, there's been a 20% increase in service utilization. When you have less, where do you go? Higher acuity. And, sorry, clicking away. The number of children who have gotten anything at all, as a percentage of those eligible, has actually dropped. The term the state uses is called access. Sorry, y'all. Too many clicks. Animation is a dangerous tool. The state uses the term access. Well, I'll do it anyway. The state uses the term penetration, which is a horrible term to use for children. The actual term is access, which means did you touch the system one time? It doesn't mean if you got what you needed. It doesn't mean it was timely. It doesn't mean it worked. It just means you called the county mental health system and they at least recorded your name and social. So that number has dropped from 5% to 4.1% since 2011, despite the horrifying data I showed you. So I'm starting to depress you because shortly I'm going to show you how we can get between $2 and $10 billion without spending any more money to address the crisis. So I'm going to land with the solution, but we have to actually tee up the challenge, is that it's a crisis of healthcare utilization that's born of structural racism and inequity. So the crisis is real, but so is the opportunity. So I told you the story of EPSDT and the Social Security Act, but now I'm going to describe for you Medicaid in one slide or less. Okay, buckle up. The way to think about Medicaid is it's a pot of gold sitting in DC. You get $1 for every dollar you put up. Basically, there's some other matching ratios, but basically, right? So here's California, ranking 42nd in the nation in spending per beneficiary, despite having the highest tax base in the nation. What? I hope you're saying, what the fuck? How did we get here? We're taxing ourselves at this level. We have more dollars to match than any state in the nation, but we're 42nd in spending. So the way I describe it is, it's like a Charlie Brown Christmas tree with a bunch of pretty Christmas tree ornaments on it. And the ornaments are the things that politicians have made their careers on. Prop 63, Prop 64, right? The millionaire tax, the marijuana tax, Prop 10, the tobacco taxes. All dollars eligible for federal match, almost none of them getting matched. So while we have serial entrepreneurship, public presentations by politicians and others about how we're going to take care of kids, what we actually get them through the single biggest entitlement is teeny. So if you want to think about Medicaid in California, think about it as a dead Christmas tree with a bunch of ornaments hanging on it. But if we could crack those ornaments open and use them to water the tree, we could flower and fund a new approach for children's health. All child-serving systems work this same way. They all have a federal act tied to a state plan, but almost all are administered locally, right? So if you've worked in a child-serving safety net, you know there's 5 of them, the big 5 we call them. There's child welfare, there's juvenile justice, there's education, early childhood, I call that a system, it's hardly a system, there's education, and there's the regional center. There's a common denominator to all of them. However poorly it's performing, it's EPSDT mental health. It covers 40% of the placement costs, out-of-home placement for child welfare. It covers 30% of all community-based services for kids in juvenile justice. Home visiting is paid for by MA and TCM. Almost half of special education costs are borne by EPSDT. And the regional center is actually a defined Medicaid 1915H waiver. That's a dollar-for-dollar matching program. So we actually have the architecture of the solution. We just got to fund it and apply it at scale with the focus on race and equity. So I'm starting to flip to hopefulness, right? Well, the problem with that system is this is how Medicaid flows to a child and family from the feds. So I drew this once for our staff, and everyone loved it so much, and now I keep presenting it. And part of it is to show you, if it's really hard, it's because it is really hard. So at the top of this chart, and I need to animate it and make it pretty, but is the federal government, meaning CMS. That's a federal dollar. It comes down to the state. But then it is sent to providers through the following 8 intermediaries. MCO, managed care, your health plans. Mental health plans, your county mental health department. The Department of Public Health, your LGA, MA, TCM, CPSP, home visiting, public health programs. LEAs are schools, SELPAs are special education departments, FQHCs are community health centers, hospitals, public hospitals and private, and the regional center. Those are the 7 intermediaries through which a federal dollar flows before it gets to a provider and before it gets to a patient and a client. So if you want to know why it doesn't work, it's because it's designed not to work. That's why. But there's an opportunity before us. If we have the courage to apply this construct, which is we decide behavioral health is not a response to pathology, it's more like an immunization than a specialty care service. It's something every kid should get, not because you have measles, not because you meet the 16 diagnostic requirements that currently trigger EPSDT, but because it's worth it as a culture for us to invest in children's social and emotional health. If we restructure our systems to expend brand new money, and if we make sure we actually claim the dollars we're already spending. And center race and equity, of course. So we actually are doing this in 4 regions: Sacramento, Los Angeles, San Francisco, and Central Valley. We start in San Francisco in January. Basically what we're doing is we're showing we're starting by doing all the data across the 5 child serving systems, showing who's getting what, when, and where. Then we're organizing with beneficiaries, making sure we're asking people what they want, participatory research process, and then we're actually teaching the city and county of San Francisco how to claim the dollars, so that by the time the dollars arrive, they'll have a narrative and voice of people who are beneficiaries to tell us how to spend it. So we will generate significant new revenue in San Francisco. But those are, I would call these incremental changes, because the real hope, this is our planning process. The real hope that we have actually isn't to help 4 jurisdictions. It's to fix it at the state level. And so to tee up how we're going to do this, if you accept that we have new and emerging practices that demonstrate the promise of behavioral health, you want to fix it? Yeah. And you agree with me that there's striking evidence of a crisis, and that healthcare system players are actually engaged in a way they wouldn't have been before because of ED utilization and inpatient utilization. And if you believe me that there's a way to finance broad reform by claiming against existing non-federal dollars in our system. And so basically what I'm suggesting is you mine those 5 bubbles for public dollars that are eligible for a match and match them. But you haven't been able to do that because of how mental health is reimbursed right now. And so really quickly, currently mental health is reimbursed through something called certified public expenditure, which means that your county mental health plan must spend $1 and then retroactively get a federal match per minute, per unit, per patient. Does anyone here bill EPSDT? If you've ever done it, it's horrible. So it's actually, I've run hospitals and ambulances and FQHCs and special education classrooms and juvenile justice and child welfare settings. Far and away the most complex and difficult Medicaid claim is behavioral health, because of the challenge and difficulty of processing the claim and the per minute, per unit, per diagnosis way it's funded. Compare mental health to physical health. Physical health gets paid by capitation. When a physical health plan gets $1, it's already matched. It's both state and federal share, and they just spend it for services. Where a mental health plan has to take 14 different sources of non-federal, fully fund a service, and then retroactively, per minute, per unit, per patient, pull down the reimbursement, wasting over 55% of its clinicians' time documenting it. We have said this type of methodology, the latter called CPE, needs to change and reflect modern claiming methodologies that hospitals, ambulances, more frankly politically connected, influential bodies access. And guess what? The state on Monday said they were going to do it. Woo! Right? So for those of you who are tracking anything like this, there's something called CalAIM. California administers its mental health system under something called a 1915B waiver. So go with me for a second. Basically in 1984, California said we're going to separate out mental health from physical health, and counties are the mental health plan. It's called the 1915B waiver. It times out at the same time that the hospital waiver, the 1115 waiver, in March of this year. The state has announced a planning process for the 2 waivers called CalAIM. The CalAIM concept doc came out 6 days ago. The first line of the behavioral health reform proposal under CalAIM says, shift behavioral health financing from CPE to IGT. Word for word, what our proposal said. So we actually now have the state agreeing to the mechanism necessary and appropriate to pull down the billions we've said. Are you with me? That's a mouthful of Medicaid finance. But what I hope you take from what I just said is fundamental payment reform is coming to California's mental health system. It should generate billions of new dollars. We have to have the courage to spend it differently. Not just in 50-minute sessions with trained professionals, but looking at social capital models, at peer-to-peer, at other practices that are actually possible in behavioral health, because the scope of practice battles are 30 or 40 years younger. If I gave you, the medical industry, $5 billion new to spend, we'd spend the next 20 years fighting out who got to spend it. Between the nurses and the PAs and the medics, I got the lashes on my back from CNA from that stuff. It's a brutal, brutal problem. But in behavioral health, Medicaid is delightfully open. The minimum requirement for Medicaid reimbursement is a high school degree and 2 years of case management experience. You can bill TCM. We could actually create a whole new model, reinvent the social contract based on leveraging the lived experience. For those of you who work in early childhood, those are the parent partners. That's extraordinary. The peer-to-peer work, the social models for those of us in recovery. How do we get sober? We got there by talking to other people with lived experience. There's an extraordinary potential of people helping each other if we but leverage it and pay for it. So what would this mean if it happened? And last two slides here. We call this the miracle question in therapy. So if I wave my magic wand and you woke up tomorrow and it had happened, right? How would you know? Like, what are the circumstances of solution? Not the absence of your problem, but the circumstance of solution. Well, first is we would redefine mental health. We wouldn't think of it as something that only happens with a therapist. It would be happening everywhere a child lives, works, or plays. We would generate a significant new investment in children and families, I believe between $2 and $4 billion. That would represent the most significant investment in children's social and emotional health commensurate with the crisis we face. And we would require new collaborative purchasing models that would get us out of each system buying for itself. There would be some entity, you could call it the Children's Trust if you want, but I prefer you didn't. Something that says, it could be your health plan, we're going to look across the child serving system, use a single assessment tool, we hope the CANs, and we're going to do a level of care instrument, and we're going to ensure that every child gets what they need. We check in with them at least every year. How could we pay for it? These are the strategies. The waiver strategy I mentioned, the growth strategy is part of the waiver strategy. The state plan amendment is a way to just basically make a change under existing authority. And we may have a different presidential administration in exactly 1 year. And if you watch the history of the opiate bill, 4 white senators voted for that bill because they had children or family who were impacted by the crisis. What is extraordinary about the youth mental health crisis is that it crosses socioeconomic status. It impacts everybody. If you got a teenager, you know that kid or their friend who's been cutting or been to the hospital or gone off to college and had a challenge. You know somebody. And what this means is that I think there will be a national response, and the most likely response historically has been increased matching ratios like Obama did for the Affordable Care Act to incent the states to buy in. I can see a federal response to the epidemic at scale where newly enhanced rates of federal matching dollars are applied, so that's our federal play. And I mentioned the regional initiatives. I'll stop there so we have a good chunk of time for questions because I threw a lot at you. And this is a conversation that is not rarely merged. Maybe it is in med school classrooms, but we're trying to suggest that if you just go get the money and don't transform how you define the benefit and what qualifies for service, you will actually double down on a broken industry, no matter how much money you add. So we'd like to invite you to think of our proposals in combination of restructured systems, redefined benefit, expanded financing, all focused on race and equity. Thanks. Yeah.
Hi.
Rhea, come join me.
So you alluded to having increased behavioral health contact for children in many different settings outside of kind of the traditional clinic model.
Yeah.
So I imagine you're thinking things like, well, for one, schools. So I'm wondering what you envision in terms of specific policies or programs that would enable that direct access in terms of like where would this money go for that?
Love it. So I will say I started my career as a therapist in the Oakland Public Schools. And I worked with Dr. Barbara Staggers at Children's Hospital and Research Center at Oakland, and we started 31 federally qualified health centers in Oakland middle schools and high schools. And I'm absolutely convinced that for middle schools and high schools, it's a comprehensive physical and behavioral health program that is either done in partnership with community health centers or where you don't need physical health because kids are healthy. You can also do it with sort of a wellness center model, which is largely Medicaid community-based organizations. In the health and school-based model, we have this thing called the MTSS. It's a funky kind of name. It's called the multi-tiered systems of supports. It's a triangle. At the top of the triangle are kids with special ed, IDEA kids. In the middle of the triangle are identified patient services. And at the bottom of the triangle are whole school culture, school climate work. And to answer your question directly, I would propose that with new financing available through Medicaid, we co-locate community-based organizations and youth development organizations in schools, embed them in the school culture and school climate through kind of actually practice lessons we've learned about how to do this and hit all 3 tiers. How to finance tier 1 and tier 2 is easier than the financing of tier 3, I forget, tier 1, 3, whatever, the bottom of the triangle. So that's more challenging, but I actually think that if you opened up Medicaid's diagnostic criteria and didn't require a diagnosis to get in, that you could also do whole school, whole culture work. So there is some argument in the field about whether it should be school district staff or community-based organizations. In Alameda County, we did it with Seneca, Lincoln, Fred Finch, and in some rural areas like Desert Valley, there's nobody. So the school district became those staff members. And it's usually some version of a licensed clinical professional, case management, youth development staff, and peer-to-peer work. And it's that kind of cascading mentorship model that works most effectively in schools.
So all of the initiatives that you spoke about in the past, there was a lot of discussion about them, and I wonder if you could talk about when the decisions were made, what we're seeing as the advantages and disadvantages. So for example, separating out the flow of funds for physical health versus behavioral health. Now we're saying it's a really bad thing, in those days, the concern was that if it's all together, behavioral health is always the one who doesn't get the funds, and that you wanted to have a separate thing. The other issue is whether counties should control the money or whether it should be someone above counties. And that has to do with the millionaire's tax, with all these things. And again, there was a lot of discussion. Is this a good thing or is this a bad thing? And advantages and disadvantages. And I wonder if you could just discuss, some of the things, because none of these things were just done. Obviously, there were people who were lobbying pro, and there were people who were lobbying against. Mental health people, and people in all the different agencies that you're talking about.
Yeah, that's a big one. But I like it. The past is prologue. You got to go back to go forward. So you have to understand where we've been. So generally, particularly for children, you're looking at kind of 3 systems with a stopgap. So the 3 systems are the regional center for disorders of development and mental retardation, behavioral health for, in theory, serious mental illness, and managed care for mild and moderate benefit. Like that's kind of how the state has laid it out. And it's a mishmash, kind of Frankenstein of reforms tied to labor interests and other stuff. But the bottom, the catch-all, is special education with an IEP. So all of you who work with kids know, right? And my wife trained here, runs the NICU at SF General. When we counsel families, we almost always say, get a lawyer, get an IEP, right? For kids who have got real issues, because those other systems are really good at not paying. They all point the finger at each other and say, no, it's your fault, your problem. And so what's the one place that will at least try to pay, however under-resourced it is? Special education. So the interaction with those 4, that's how that system has evolved, that witch's brew of ugliness, of people pointing the finger and families not getting what they need, and almost always devolving to IEPs to actually get what they need. The history of the carve-out is a troubled one. And I think you narrated it well. It's a combination of sort of progressive politics about a public system versus a commercial system, separated out and privileged, but it's actually been imprisoned in dysfunction. And part of that is because those county systems tend to be interacting between public safety and health and human services. So I still bear the scars of negotiation with the sheriff and the DA when it was me as the health director in Alameda County. So those local jurisdictions are fraught with political battles that have no relevance to trying to get stuff to people. So I think your question was, how did we get here from there? And a series of misguided, fragmented decisions, largely that have not been done with a lot of transparency. So the future, and really if you read the CalAIM document, which is actually 181 pages, so you probably don't want to read it, but it actually says 2 things. It says doubling down on managed care organizations as the central broker of care. So the state has said that your health plan is going to be the central place to do care management and care coordination. But it retained the role of the mental health plans for people with serious mental illness. So we still have a bifurcated system, and the state has, besides a little pilot where it's going to attempt integration, it has not made a real movement towards integration. We could talk about that one forever. Sorry to be so mealy-mouthed. Yeah.
really like the vision for seeing kind of behavioral health being more like immunization, and I love the fact that we're in a perfect time in history with this perfect storm with the waivers coming up. I guess I'm wondering what you've been thinking of or what you've heard of with the waivers and taking advantage of thinking about our primary care and pediatric partners who are increasingly, as we know, dealing with a lot of the behavioral health issues, and we're putting that on them for good reason because of the workforce, and that's where the patients are going. But have there been discussions about reimbursement at higher rates for the pediatricians and to be able to do this work and actually have the time to do it? Because I'm very concerned that until we really move to what you're talking about, it's going to be a while, right?
I love that question. Thank you so much for that question. So we literally just put out about a month ago a paper with Alicia Lieberman from UCSF, which actually proposes a specific type of investment for primary care to co-locate community-based organizations in the primary care home to do behavioral health, dyadic therapy, case management, and social determinants work. So if you go to our website, www.childrenstrust.org, you will see, and go to our work, you will see the paper we just wrote with Alicia, exactly answering that question. Children, remember how I said 85%? Like one of the untold stories of poor people is they get their kids to the doctor more than privileged people do, despite the burdens. It's like an extraordinary thing that happens. And so obviously for kids 0 to 5, because of the adherence to CHDP, and I know we have lots of challenges with it, but actually little kids get to the doctor. We want to leverage that relationship for 0 to 5 in primary care and go right at a primary care integration strategy. Co-location, peer-to-peer, community connection, right in primary care. And we propose in our paper a way to pay for it through something called a provider incentive. It's a fancy little trick, but it's a way to enhance capitation to dedicate dollars to a primary care center for that purpose. So you can read about it there. But then when you get to age 5 or 6, primary care utilization falls off a cliff. In fact, adolescents have the lowest rate of primary care utilization of any demographic group. That's why we have to restructure our system. If you take mental health as a traditional health system, like wait for a PCP referral, it ain't going to work. First of all, what we used to say in adolescent health is if you want to kill volumes, put police or parents in the waiting room. Young people are individuating. That's a term from Eric Erickson's work. They're separating from their primary care group. They're seeking a sense of definition distinct from their parents or family caregivers. And so we must provide care and support, and that's what makes schools such a perfect secret sauce. We call it like peanut butter and chocolate. Like you should put schools and mental health together because kids are there, you can access them, and that's the time when they have the highest incidence of behavioral health concerns and the least access to primary care.
I really appreciate the stance towards like not pathologizing behaviors that are existing in a certain context and finding ways to generate money that's like sort of accessible. I guess the thing I struggle with just in hearing the perspective is like we act like there's no money in California. Like this is like an extremely wealthy state with like lots of like very large corporations, and somehow we can't seem to find the money to pay for anything. And I don't know if, obviously it's in some ways a little bit of a pipe dream at this moment in time to think about leveraging the tax base and like actually taxing people what they're worth. But I don't know if there's anything that you could share with that regard about like things that you would like to see, things that you think are possible, just because it just feels very strange to live in the state and there not to be money.
Yeah. So I will, they're actually, the level of taxation is of course not sufficient, but it's high enough to generate billions of dollars of match. We're just not claiming it. So the two obvious examples are Prop 63 and Prop 64. Prop 63, millionaire's tax, passed in 2004, I think, and produces about $500 million a year. And very little of it is being effectively claimed to Medicaid, though all of it is eligible. Prop 64 is the new marijuana money. It's $400 or $500 million this year, but it's going to grow to $2 billion, an extraordinary source of non-federal. So the way I'll answer your question is, the trick to Medicaid is to be like a gold digger for non-federal dollars. Like if you want to distill my professional career, even though I can't do Excel, and part of white privilege is everyone thinks I'm good at math, like I fail calculus, can't do Excel, but I have spent my career seeing poor people not getting what they need, and the way to get them at least something, though I'm learning it wasn't the right thing, was to go find the non-federal dollar. Because every time I could find a non-federal dollar, if I ran it through our plumbing, we could pull down a match. So how did we do that? Well, we had tobacco money. Remember the Master Tobacco Settlement lawsuit? We got $8 million. That's what drove a 10,000 kid expansion in Oakland Public Schools. We had a half-cent sales tax in Alameda County called Measure A, $130 million a year. We used that to claim against. I could go on. That kind of entrepreneurial hustler spirit, we got to bring that to the state. Because I think by asking 58 county safety nets to hustle and find the non-federal dollar, we actually use 16 sources of non-federal to claim EPSDT mental health. So I think it's too hard to do it that way, even though it appears it can be done. Like, there was a newspaper article that came out about some work we did in Alameda County that said, Alex Briscoe was out hustling the money, how come other counties don't do it? And I think that article was actually destructive, because it created this image that it could get done, and I don't think it can. I think the state has to fix it by matching it all at once, and that's that CPE to IGT play that I named in the beginning, that the state just announced 6 days ago they're going to do. So to your question, yes, we need to fix the prop, whatever it is, on property taxes thing. We got to get that right? We definitely have to tax wealthier corporations and people a lot more, but we also got to claim against the dollars we're already taxing.
I would also say, one of our challenges when we give these presentations is that we focus a ton on the money, as if the money is enough, right? Like that regional center data told us, like, money flows away from kids if you're Black and Hispanic in the regional centers, which makes no sense, right? So more money won't necessarily solve it. And I think your question about MHSA is a great one, right? There is hundreds of millions of dollars sitting in MHSA coffers in counties across the state. Like, money isn't necessarily the problem. But what brings most people to our conversation, I think, is the idea that we talk about money, which is also something I think we all have to think about. Like, yes, we need more money in a certain sense, but why is that always the way that we have to think about change? And does that sometimes prevent us from making the types of changes we need to address some of the inequities that already exist minus the money, some of the kind of dysfunction, I guess, we've been saying?
Love it.
Yeah, actually, to expand upon that, so I found myself wondering, in terms of the social justice piece that you brought up, it seems like obviously that kind of ounce of prevention, how to cure element plays out there as well. Are you guys involved in that space, or who are you partnering with to look at ways that we can affect that aspect of change that's affecting in their neighborhoods?
So early on in our process, we developed kind of like teams to approach each triangle of our work. And so we had like an equity-centered team that we populated with nonprofits that do kind of anti-racism work. Young Women's Freedom Center is one example. RISE in Richmond is another. CYC is another. Who are all of our... I'm missing like 6. There's so many. But anyway, we talked to like a number of organizations to think more about it, to help push us out of the idea that it's just more money, that we also have to think about how systems function, because a lot of these groups were also in the negotiations kind of when MHSA happened, and it seemed like, oh, a ton more money is going to come, but then it didn't roll out any differently. So I think one of our other challenges is, to that question before about like, will we reimburse pediatricians more, is like pediatricians are already kind of getting paid, and they don't have as much time as they need. But you know who's not getting paid at all? Like parents or kids to be peer supports for other kids. Like, there are people who could join this quote-unquote workforce in the setting of this shortage that would more equitably distribute resources across the state, which would address one of the root causes we're talking about, which is inequality. And one of the hard things to say is that our healthcare industry is a part of growing inequality, because we don't, right, we have all of these certification requirements, and you need this and you need that to participate, and then we say, but you're the main person that has to do this, so we're going to give you a parenting class. You know what I mean? It's like, are there different ways that we can include nonprofits and parents and peers in this same workforce to serve kids' social emotional needs in a way that we don't right now. And I would say some of the nonprofits we've been working for have helped us think more about that, because they would be the first place we would be like, you should be able to bill Medicaid for what you do.
The strategy for getting there is create an opportunity for more money and break out of the medical necessity box. I didn't mention in the CalAIM proposal, there's two big wins. This first is the CPE, the IGT Medicaid piece, but the second is the state has proposed removing diagnosis as the triggering event for EPSDT mental health. So for those of you who build it and know you have to certify one of 16 diagnoses to get reimbursed, the state has actually proposed moving to a level of impairment model, a CPT coding approach, that would, in theory, open up Medicaid to both community-based organizations and to children before they achieve symptomatology or diagnostic levels. Oh, and by the way, we were going to, a summary of the CalAIM document will be available on our website by 4 p.m. today. So if you want to see the 181 pages in 4, you can check that out. So.
Thank you very much for two very excellent, concise presentations with wonderful recommendations that we all should back up. Do you want to spend 1 minute charging this departmental faculty with what we should be doing to understand such things as how to cope with adverse childhood events?
Wow. Big ask. I would say a couple of things. I know you said one, but we need a bunch of things, and I'm going to let Alex list some things too. One is thought partnership around what it means to have like an anti-racist behavioral health intervention. Like, honestly, when I look around this room, I see providers that don't reflect the beneficiaries of Medicaid. And I think it's a major problem, not just because there might be like cultural differences in how you relate, but because that's a source of wealth and income inequality that drives some of these issues. And so if we're talking about shifting power, I think perhaps we all could think about ways that we invite more people into how we provide services or care for other populations. And when I say invite them in, I don't say come for free and come for lunch. I mean like employ people differently. I think that's something that we're challenging ourselves to do, and we would love to be in partnership and thinking around like how are we all approaching this in an anti-racist way. I think the other one is that even though we always say the scope of practice, fights are kind of not as hard in behavioral health, the people who fight the hardest are the doctors. CMA fights really hard to make sure if any new money's coming in, it always goes to a doctor to pay for their time. And as a clinician myself, who works in urgent care, who sees behavioral health issues that we have no support for, I also don't want that money to go to my time. I want it to go to communities who literally aren't getting paid for anything that they're doing, and they're there every day with kids supporting their social and emotional development or kind of contributing to impairments. So I also would say when these scope of practice arguments come up, because they inevitably will, if you are a part of a group who comes to that table, if it's your professional association or it's CMA or whoever it is, please be that voice in the room that says, actually, do we need that extra dollar for our time, or can we give it to another organization? Or can we share it in some way by co-locating services and both getting paid?
Amen. I think we're at time. Thank you so much for listening. www.cachildrenstrust.org if you want more information or to read our policy briefs or to see a summary of the CalAIM report. Thank you.